Thank you for introducing me. So in the next 15 minutes, I'll give you an overview of what we found to be an exciting question using our FMT butyrate intervention study, what matters in microbes or metabolites or both. This is all known to you, but I think the consensus now is that for metabolic syndrome or type 2 diabetes, low diversity and low butyrate producers are present, especially in the colonic fecal material. It's not so much known for the small intestinal part where most of the metabolites, most of the metabolism is driven, because that's where we take up our proteins and our glucose. And I think a way to get into an idea whether these butyrate producing bacteria and these bacteria per se, colonic bacteria, are driving metabolism, we do often fecal transplants. A fecal transplant is the cartoon what you see here, where at least in the Netherlands we always infuse via the small intestine, so that we can also expose the small intestine with new bacteria, and in the US they usually do colonic infusion. We've done predominantly until this study, which we're presenting now, lean healthy subjects, which show that, and this is published as well, so we'll go over it very quickly, that if you transfer feces from a healthy, lean, young subject, that you can improve glucose metabolism, and it's driven mostly by changes in butyrate-producing bacteria. But we also see that some people are responding, some patients, and some are not. But the major question, of course, was, and that we only tackled in our last paper, is we think that the bacteria itself do not drive the systemic effect. It's probably the metabolites produced by these bacteria, as Francois said, that are driving the systematic effect. For example, butyrate, which is not only burned up by the liver, but also has some systemic effects. And in this case, butyrate is the one that we could, at least for this study, buy GMP produced and give back to patients in capsules. The other two, acetate and propionate, are harder to get by. Then the final thing for the introduction, which I think is important to realize, is that there's many animal studies showing that if you transfer feces from humans to mice, that you can see some effect, both on weight and also in this case on host serotonin biosynthesis. I think we have to take them very cautious, these data, because it's usually within the noise range, but at least what they showed is, and this is the work from Elaine Tsao, that if you can affect the tryptophan, basically serotonin pathway, by just transplanting feces from one mouse to another. We checked that a little bit in our paper, in which the PhD student that I showed you on the first slide, Annick Hartstra, who did this MyNewGut trial, worked on as well. And we found indeed that if you give transfers, you can change plasma metabolites. It's in the paper, but you can see that if you give healthy donor stool, you can see increases in tryptophan. If you give people their own stool back, you can see many oxidative stress and lipid signals coming up. I think the most important link we have not made, and now we're going to our data, is that there's other donors to use, which are also lean people that lost a lot of weight during bariatric surgery. Data from the Netherlands show that if you do bariatric surgery, you can change the dopamine and serotonin receptor expression in the brain. So here you can see controls. The open rings are the people after surgery, and the dark rings are before surgery. So you can see an increase in the expression of dopamine receptors in the brain. And this is all driven just by the bariatric surgery, the people claim. And another mouse study once again said if you transfer feces from one bariatric surgery treated mice to another, you can change beneficially weight and microbe composition. So we just wondered, does it exist in humans? Does the gut-brain axis exist in humans? And in 2013 we had not really a clue, but we could postulate that if you change part of the microbes via either the nerves or via metabolites, you can do something on the brain, either via neurotransmitters, for example serotonin or dopamine, or unknown metabolites, but you can also do this via the fecal tone. So we did a randomized controlled trial, which we now finished, and most of the data are there, in which we just asked two simple questions. If you give feces from a lean subject that had undergone bariatric surgery, of whom we know that they have changes in their dopamine receptor and serotonin receptor expression in the brain, can you transfer that phenotype to a person that is metabolic syndrome and has not had an operation? And the second one is this butyrate really so important because everybody claims that low butyrate is associated with adverse health. Can you just replace it by a pill and then the problem is solved? So we did a RCT in 2 times 12 subjects, both males and females at that time, treatment naive, and either they were randomized into receiving placebo tablets from the same manufacturer as the butyrate manufacturer, and received feces from a post-bariatric surgery donor who lost a lot of weight, about 40 to 50 kilos, and was now normal weight, lean. Whereas the other group received butyrate, 4 grams for 4 weeks, and received their own feces. So it was totally blinded and nobody knew what they would get. This is what I showed, so it was fully randomized, and we had basically three different primary endpoints which were all interconnected. The first one is the easiest one, we think, is do the microbiota change. So we took fecal samples and small intestinal biopsies to check if they changed over 4 weeks after the intervention, both butyrate and the FMT. Second is the glucose metabolism, both of the liver and the muscle. And the third one was the effect on brain and dopamine receptor expression in the brain of these people at baseline and after 4 weeks. So this, once again, is the trial. You do all these measurements at baseline, then you randomize them, and 4 weeks later you once again do feces, MRI, biopsies, clamps, and brain scans. Just to give you, because we have a little bit of time before I go to the data, to give you a little bit of insight, a clamp is totally different than an oral glucose tolerance test. A clamp is regarded the gold standard, but it costs a lot, takes a lot of time, because you infuse stable isotopes, labeled glucose, over a day, and you basically increase the amount of glucose that you infuse, and by that way you can decipher how much the insulin sensitivity of the liver is and how much the glucose uptake of the muscle is. And there's basically no other way to do this than by a clamp, which by that way is the gold standard. The other thing we did was a brain scan after infusion of a tracer, which is an iodine tracer, and it binds in the first 2 hours to the thalamus and the hypothalamus, which are basically here. The green is the thalamus, the hypothalamus is here. And it also binds in the striatum, where the dopamine receptors are located in the brain. So what you will get is an image of a SPECT scan, which is the tracer scan, and you link the MRI scan of the people over it, and basically you can find what's happening in terms of receptor expression in the striatum, dopamine, thalamus, and hypothalamus, as you can see over here. So we finished the trial about a year ago, and people were quite well randomized. We had females and males, as you can see here. They were quite insulin resistant, had a rather high HOMA, so our screening was successful. And the first question we asked, of course, was what does happen to the fecal microbiota composition? So together with Yolanda Sanz's group at CISC, we did the 16S sequencing, and what we found is that, and this is a change, of course, in time between when you give post-bariatric allogenic fecal transplantation plus placebo capsules, you can see a change in specific bacteria, which I'll come more closely to in a minute. But you can find some bacteria that you expect to find, like Alastipes, but also Privitella. Whereas after butyrate pills and own feces, you can see some different changes in bacteria, which are mostly into the Bacteroides uniformis. So we zoomed in a little bit, and it's interesting, we did our own analysis by our bioinformatic group in the Netherlands and the group of Yolanda Sanz, who found similar strains to pop up, which is always good because we use different bioinformatic pipelines. And what we showed is that after post-bariatric surgery, allogenic fecal transplant, we found increases in Privitella copri, whereas when we give butyrate plus their own feces back, we saw increases, especially in the Bacteroides uniformis. There were other strains as well, but these were the ones that we focused on. More interesting was that compared to lean, healthy donor young males that we usually use for donors, the post-bariatric fecal donor samples had absolutely no effect on weight, absolutely no effect on dietary intake, and absolutely no effect on both either glucose metabolism of the liver, endogenous glucose production, or peripheral glucose production in the muscle. And you can see here that there's not even a trend. This is within the noise. In 2 times 12 people, we don't find the same effect of an FMT nor butyrate on either peripheral or hepatic glucose production. The other thing we wondered is, can you find something on the appetite and impulse control regulation? And for that we did two things. Of course, we did questionnaires, and I'll show you the data here, but we also did, of course, the brain scans. So in the questionnaires, you can already see that there's a lot of noise, either in this case for, I have to look as well for the hunger signal here. You can see that if you do a delta, so you do before and after, you can see some changes, a beneficial change after post-bariatric surgery, and then, well, a decrease, and this is a VAS score after butyrate. But as I said, it's more important to look at the brain scans. And the brain scans, I think, showed some interesting data, although, and I'm going to take you through these data a little bit more slowly, there is an effect, and the effect is not noise. The absolute numbers show that after butyrate, you see decrease only in dopamine receptors in the striatum. There's no effect on serotonin receptors in the brain, in our hands. And you see an increase of these dopamine receptors after bariatric surgery donor fecal transplant. If we do the same, what is published in literature when you use a delta, so you take away you use the delta difference and take away the baseline noise, there is a significant effect, which is similar to what happens when you give people a specific diet that gives them 7 kilograms of weight loss. So post-bariatric surgery, FTX, gives an increase in dopamine receptors in the brain, whereas butyrate gives a decrease, and of course because of this difference, but it was a primary endpoint, there's a significance, but it's a comparison to what is published before in the literature. We then wondered how this links to either microbes or metabolites in the blood, and this brings me to the final part, the final 3 minutes of my talk, where I will guide you through the bioinformatic analysis that we did together at the AMC. So first question was how, and I'm sorry for the small numbers, but how does the brain scan delta correlates with specific bacterial strains that we found to be altered upon either bariatric surgeries or butyrate. And you can see that only there was a significant correlation between brain scan dopamine receptor expression and Prevotella. And for butyrate, we found a significant correlation between the change in brain scan dopamine receptor and the Bacterius uniformis. So can we link this in any way to what is published in literature? And we can find a little bit, and this of course is work in progress. We found that at least Prevotella copri is decreased in patients that are having Parkinson's disease, which is a similar disease where you have changes in your dopamine receptor expression in your striatum. And Prevotella copri increases when you give diet that improves patients' health, metabolic health. And Bacteroides uniformis, I think Yolanda will show us maybe some more data, but they found a strain that is at least associated with a beneficial metabolic profile and immunological profile. So then finally, and this is the last two slides I'll show you, we did some analyses to look at which fasting plasma metabolites on the left side and urine metabolites we found after both interventions. So the upper one is after bariatric surgery, feces before and after, this is a heat map, and this is after butyrate. You can see that the changes are different, so the bariatric surgery has a different effect on plasma metabolites than the butyrate. The effect is stronger in plasma metabolites than in urine metabolites. And Sandrine Klaus is now looking into which metabolites are these ppm values that I'm presenting to you. And then finally, we looked at whether the change in plasma metabolites is linked to either a bacterial strain, and we found some associations there, but for the sake of time, I won't go into it. The most important thing I wanted to show to you is that indeed we found some metabolites, which are 2 ppms that are correlated with the change in dopamine receptor expression in the striatum, whereas in butyrate, we see different plasma of metabolites change with the dopamine receptor expression. So my take-home message is that in contrast to this animal work, we can show that in humans fecal transplant changes bacterial composition and butyrate changes bacterial composition, but that there's no strong effect on glucose metabolism if you use a post-bariatric lean donor or butyrate on receptors, on a recipient's glucose metabolism. Absolutely no effect. So that's not in line with the animal data. But what we do see is that there seems to be a gut-brain axis, although I think our trial was underpowered to find it in absolute numbers, but in the way in the literature that you described, you can find the difference there, that bacteria can change the dopamine receptors in the brain. And we have not seen that before. And if you look deeper, you find both bacterial strains that are known to be associated with a specific biochemical pathway, in this case dopamine metabolism. And we found 2 metabolites, as I said, which Sandrine is working on, that are correlated with these changes. So the question was, what is driving metabolic effect and how big is the effect? I think there is a gut-brain axis. I think microbes and metabolites play a role in humans, obese humans. But we don't know how large it is. It's smaller, but it's probably significant, and they probably matter both. So with that, I would like to thank you for your attention and open for questions.
Thank you very much, Max, for this talk. Are there questions from the audience? Oh, 2 hands are raised. First, this one, the lady.
I was very impressed by your data showing a connection between the bypass gastric or bariatric surgery and the dopamine receptor in the brain. So my question is, because we know that dopamine is very important for addiction, so do you think that the patient with bariatric surgery are more susceptible to develop addiction?
Yeah, and that's already known. So based on questionnaires, people after bariatric surgery usually have they are more addictive, so they have more alcohol addiction. And second is they usually change also their impulse control. So they go into, we have a large bariatric surgery cohort where we question this. You see differences in partners, differences in sexual behavior. And it might be related to this, might also be just because they suddenly lost 30 kilograms of weight and they're able to move around and do stuff that they did not do before. But alcohol addiction is known, they have a 4-fold risk after bariatric surgery. So that fits.
Okay, thank you.
Short question? Max, maybe you can first introduce yourself and then...
Max, your first data on lean donors,
the
lean donors which induced metabolic improvement.
Effect in about 60%.
And in opposite to the for the
post-bariatric surgery.
Post-bariatric surgery, still butyrate may or may not induce the effect. So do you have any explanation if butyrate does not do the job? In this case, how is then the lean donors modulating?
Yeah, it's a very good question. So in our 2 different trials we found also changes in acetate producing bacteria. That's the cell metabolism paper. So it could be short-chain fatty acids, but I'm much more in favor of other metabolites that we don't know of that are present in lean feces. Might be phages, might be metabolites that drive the effect. I'm less fond of giving pills like short-chain fatty acids, propionate, or butyrate as a treatment because that doesn't seem to do the trick. It's more that probably the body has a reason to keep the butyrate and short-chain fatty acids down in these obese metabolic syndrome subjects, and it doesn't want to be supplemented. And we reproduced our findings in another study as well. Butyrate has no effect when you study with the clamp in 2 different cohorts.